Yes, students, am I audible to all of you?
Yes, ma'am.
Okay. So I hope this class will be a very interactive class. We have to discuss, we have to clear the doubts, and which is only going to be the high yield topics for your exam, which is going to help you to clear all your screening exams that you are targeting for. All right. So let's start with the mock test for today. This is our team. Everyone must be knowing. Today, Munjal sir is not here. He's busy a bit. Dr. Aarti, Dr. Madire, that's me. Dr. Ramya, who will be conducting the second class. Dr. Sonal. I guess who have joined the regular classes, you all must be aware with all of us. Okay, so let us start without delay for our first question. So, Dr. Anisha, can you read out this first question for me?
Yes, ma'am.
Yes, please.
An 18-year-old male college student is seen in the student health clinic for urinary frequency, dysuria, urethral discharge. Which of the
Hmm.
following is likely to explain his condition? Options
Okay.
are herpes simplex, E.
Hmm.
coli urinary tract infection, chlamydia, urethritis, syphilis, and HIV infection. How you
Hmm.
diagnose and treat?
Okay. So, how will be your approach for this? First, tell me what are the main words in this question that we see. It is a 18-year-old male. That is a young male. Okay. And he's coming
Okay.
with urinary frequency, with
Mm.
dysuria and urethral discharge. These are the four main words. So, now, Dr. Anisha, please tell me how will you go ahead with this?
For this, we had to check the urine analysis
Okay. But do you think whether it is cystitis or it is urethritis or it is syphilis, how will be your approach?
Most probably, it is chlamydial urethritis
Okay. And why do you think so?
because this patient is a student, young student, 18 years, and
Okay.
the symptoms are urinary frequency, dysuria, and there is discharge also. So, most
Okay.
likely, I'm thinking this chlamydial urethritis.
Okay. Fine. Yes, Dr. Mifra, you're saying it is gonococcal urethritis?
Non-gonococcal urethritis.
Okay. Non-gonococcal urethritis. And
Yeah, urethritis is also my answer is also C.
okay. The correct answer for this question is C. Very good, both of you. But now, whenever you see such type of a question, that 18-year-old male, dysuria, urinary frequency, and the key pointer here is your urethral discharge. So, whenever we
Right.
see this urethral discharge, that time we have to completely shift our focus from cystitis to urethritis. And urethritis is basically a sexually transmitted cause. Okay, so any type of urethritis that we come across has to be a sexually transmitted urethritis, right? Now the main causative organism for this chlamydial urethritis has to be what? What is the name of this? Yes, chlamydia trachomatis. Yes, it also causes eye infections as well. So, chlamydia trachomatis, and it is going to cause you all the urinary irritation, the sexually transmitted urethritis. So, it is gonococcal urethritis, but not gonococcal urethritis. It is a sexually transmitted disease, my dear. Now, let us see how will we approach this. No, it is written here, especially non-gonococcal. Has to be gonococcal. Let me just cross check with this fact. I'll come back on this whether it is non-gonococcal or gonococcal. According to me, it has to be a gonococcal disease. Fine. So now when we talk about urethritis, what are the main sign symptoms? There is going to be a visible discharge, there is going to be inflammatory cells, and there is going to be the first void urine, that is the first urine sample in the morning. It is going to show us what? It is going to show us pyuria. So whenever sometimes they can also tell you that the word pyuria, the presence of pus cells in the urine. Okay, so presence of pus cells in the urine is going to show you pyuria in case of this chlamydial urethritis. The another most specific test to diagnose this is going to be your nucleic acid amplification test, that is your NAT. Just like in TB we do CB-NAT, for here, same NAT test we can do, that is your nucleic acid amplification test for the first void sample in the males. Sometimes it can also be the test which is used for Neisseria gonorrhoeae. So Neisseria gonorrhoeae, at times it is going to show you the same type of infections just like your chlamydia. Okay, so now the two things that we always remember when we do urine analysis, there is going to be pyuria. If you do a confirmatory or the more specific test, it is going to be the NAT test for this. Now, whenever we are screening for this, along with the screening, always do your HIV and your syphilis, because we know that urethritis is going to be sexually transmitted. So therefore, HIV, syphilis and your hepatitis B. The serology panel should also be cleared for this. Okay. Now, what is the drug of choice? How do we manage this chlamydial urethritis? The main drug of choice here is going to be doxycycline or azithromycin as a single dose. But in clinical practice, what we prefer is daily doxycycline 100 milligram twice a day for 7 days, which is most effective, especially for your rectal chlamydia. Now, when we say rectal chlamydia, that everyone knows that sometimes the infection can be the descending type, which comes from the bladder, as well as it can be from the rectum, and it can cause a total overall peritoneal type of a infection. That's the reason that we give doxycycline 100 milligram twice daily, which will also have a broad spectrum coverage. If not, if doxycycline is not available, we can give azithromycin 1 gram as single dose. But if I have to say I have to give some intramuscular type of injection, what will be the drug of choice for gonorrhea, intramuscular type of injection?
I am ceftriaxone.
Ceftriaxone.
Yes, very good.
Ceftriaxone.
So, yes, so it is going to be cephalosporins. Okay. So, cephalosporin or ceftriaxone will be the drug of choice. That is going to be a single dose ceftriaxone for gonorrhea. And what instructions will you give to the patient? What will be the instructions that you will be giving to the patient?
He has to abstain from the sexual activity for 7 days.
Very good. So, abstinence from the sexual activity for 7 days. So, 7 days there should be no physical contact. Also, hygiene maintenance is important. Then, retest after how many days? Retest we'll do after how many days?
3 months.
Yes, retest after 2 to 3 months is sufficient for checking whether the infection is completely gone or not. And here, the partner is also supposed to be treated. The same treatment is also supposed to be given to the partner. Just remember this important thing. Okay. So, partner management, everything. All sexual partners for 60 days must be treated 7 days after completion. Co-treatment for gonorrhea, 500 milligrams ceftriaxone. Okay. So, what can be the differential diagnosis for your dysuria in adults? In adults, we majorly see the complaints of dysuria. What are the causes? First, it can be either dermatological causes, the localized causes. It can be due to your lichen, your psoriasis, Steven-Johnson syndrome, Behçet syndrome. If it is infectious, which is in our case, it has to be a sexually transmitted disease, cystitis, urethritis, or sometimes can be your pyelonephritis. What is the most causative organism for pyelonephritis? Most common? Pyelonephritis. Most common causative organism.
E. coli.
Okay. E. coli, and another one, the expected answer is Staphylococcus. Okay. Staphylococcus, streptococcus. These two can also be one of the main causative organisms for your pyelonephritis. Now, coming to the non-infectious causes in both men and women can be at times. Yes, someone is giving any inputs?
यहाँ पे देखिए सिलिसम डाल दीजिए डालिए से मार लो
Dr. Sudesh, are you trying to give some inputs? I guess we need to mute him 1 minute. Okay. So where were we? We were on the non-infection and infectious cause. So non-infectious can be a foreign body, that is a stent, a stone, or at times it can be urethritis, which can be due to the reactive arthritis. Also, at times, due to any drug or food related, sometimes we can think, how can a drug or food related cause us dysuria? But yes, due to the drug and food related, there can be dysuria. Sometimes the spermicidal jellies are there, topical deodorants, some type of fancy talcum powders, they can also cause you dysuria. Also, there are bladder irritating foods. Bladder irritating foods, like majority of the times, foods which are rich in proteins, red meat, so that can cause you dysuria. So when we talk about the list of bladder irritating foods in UTI, majority of it is going to be your red meat, then it is going to be your nuts, it is going to be your tomatoes. So there was a question on bladder irritating foods in Kuwait medical exam. So bladder irritating foods, if you want to know, it has to be your tomatoes, then your red meat. Also at times can be your too much of sugars, like processed sugars, so you can call it as bakery and cakes, completely desserts at all the three times the person is eating. Also artificial sweeteners, completely, if someone is having, like, they are boasting, I'm eating sugar free diet, but that diet is not sugar free, you're eating three times desserts which has artificial sweeteners, and you're having diet coke completely, like 4 to 5 cans a day, that can also be your bladder irritating foods. Now coming to the differential diagnosis of various types of urethritis that we come across, let us see what it is. So, urethritis with STI, that is with sexually transmitted diseases, there are four things that we have to keep in mind, especially five, but majorly four. That is your chlamydia, your gonorrhea, your herpes simplex, syphilis. Okay, so syphilis either in the first stage or second stage. When we talk about chlamydia, that was a case here. What is the main causative organism? Chlamydia trachomatis. Okay, now what will be the clinical features? There is going to be mucoid or watery discharge. This is the main thing. That is, the discharge is going to be whitish in color or semi-transparent. At times can be watery. Milder dysuria, more frequency in urination. The most specific test that we are going to do, we are going to do NAT test with the urine or with the swab from the genitals. Then the causative organisms can be your chlamydia trachomatis. It can be accompanied with gonorrhea. Therefore, we have to screen for HIV, we have to screen for syphilis as well as hepatitis B. Here, the treatment is also given to the partner. The drug of choice will be doxycycline and azithromycin. Now, shifting our focus to gonorrhea, the Neisseria gonorrhoeae, it is a gram-negative diplococci. Here, what will be the symptoms? Severe dysuria, and the discharge will be thick, purulent. So, it will be moreover pus type of a discharge. The rapid onset of the symptoms will be there. 2 to 6 days, the symptoms will be very much at peak. There is going to be very high grade fever in this. Here also the same test we are going to do, that is NAT for the urine or the swab culture. Chlamydia gonorrhea, again we have to check for HIV and syphilis. The drug of choice here will be ceftriaxone intramuscular and doxycycline for 7 days. In gonorrhea also as well we have to treat the partner, not only the single infected person. Now coming for HSV, that is your herpes simplex virus. What is happening here? There are painful vesicles on the genitals and there is severe burning, dysuria. But symptoms of the system, that is the systemic symptoms, they are more prone. So the patient will have fever, he'll have malaise. There will be other complaints where HSV will be triggering him. If he is a diabetic, then the symptoms will be more worse. Also here the test that we are going to do, now we are not going to do nucleic acid amplification, but here we'll do viral PCR for HSV1 and 2. And the drug of choice will be same, that is ceftriaxone intramuscular plus doxycycline. Alright. Now coming to syphilis. Syphilis, what is there? Syphilis, there is going to be Treponema pallidum. Treponema pallidum, the most causative organism. Can anyone tell me how do we check Treponema pallidum under microscopy? What is that technique called?
Background microscope.
Yes, very good, Dr. Piyush. It is dark background uh, microscopy. And we see fluoroiminescence in the dark background microscopy. Now here in syphilis, everyone must have known that syphilis I have taken already in my last classes. There is going to be a painless chancre, that is your first degree primary lesion. After that, this chancre, this will be there for months or maybe years. Then we'll have the inguinal lymphadenopathy and non-itching rashes, which is going to be your stage 2, or it is going to be a secondary syphilis. The drug of choice in syphilis is going to be your penicillin G intramuscular single dose. Along with that, sometimes you can give a cyclovir, valacyclovir if needed. Sometimes syphilis can also be accompanied with HSV. At times, whenever in clinical practice you are seeing the patient, it is usually not single factor which is affecting. It can be a combination of two organisms, or it can be a combination of two diseases. So a person who is diabetic, he's maybe 50-year-old, or let us take it 45-year-old, he is having chancre as well as he is having painful vesicles also. It can be HSV with syphilis. That time what do you have to do? You have to give acyclovir or valacyclovir along with your penicillin G. That is antiviral and antibacterial, both you are supposed to give. Is it clear? Is the urinary infections, that is urethritis, clear for all of you?
Yes, ma'am.
Yes, ma'am.
Okay. You can ask me any questions about this urethritis if you have in mind. Or 1 minute, let me just ask you a question. Fine. Supposedly there is a 28-year-old man with painful vesicles and complains of dysuria and no discharge. What is it?
Base simplex.
Yes,
HSV.
HSV. HSV. What will be the drug of choice for HSV?
Ceftriaxone plus
Ceftriaxone.
Plus,
doxycycline for 7 days.
Ceftriaxone.
yes, right. Now then, at times if we are required, if the presentation is coming to you within the first 5 days or the first 6 days after being affected with HSV, rather according to the international guidelines, first 3 days. But in clinical practice, even if the patient is coming to us with the first 5 days, we give him antivirals. So whether the patient is coming to you as per the book in first 72 hours after the symptoms arise, you can give him easily valacyclovir or ocyclovir. But after 3 days or after 5 days, these antivirals are of no use. The disease is going to take its own course and get it healed in a typical period of time. Now, next question. If there is a 33-year-old female with purulent discharge, NAT testing shows Neisseria gonorrhea. Tell me the drug of choice.
1 dose of penicillin G intramuscular. And we can continue with the
Neisseria gonorrhea, my dear.
Ceftriaxone plus doxycycline.
Ceftriaxone.
Yes, there will be ceftriaxone plus doxycycline. Okay?
not a
Yes.
single dose of penicillin G.
No, Dr. Abada, penicillin G will be syphilis.
All right.
Is this syphilis?
No, it's gonorrhea.
Yes, it is gonorrhea. NAT is showing us Neisseria gonorrhea, and there is purulent
Single
discharge.
dose of ceftriaxone, single dose of ceftriaxone along with doxycycline for 5 days.
Yes, very good. So I guess urethritis concept is clear for all of you.
Yes, ma'am.
Also, one more thing that I had mentioned. If you get a patient of urethritis, what other 3 diseases that you will be screening for that patient?
Hepatitis B, HIV, and C.
Yes,
Syphilis.
very good. So it is going to be along with urethritis, you have to see for your syphilis, HIV, and hepatitis B. All right. So this was all about your urethritis. And a recent question which came KMLE was bladder irritation foods. So red meat, bakery items, artificial sweeteners, tomatoes. Ask the patient to refrain from all such type of foods. Okay. So next question. Yes, Dr. Piyush, please read this question. Is Dr. Piyush around? Okay. Someone read this question, please.
In progress.
Patient with mucormycosis should be treated in a tertiary referral center with subspecialty units experience in the care of condition and the underlying causes. Correction of the underlying abnormality and the prompt institution, which of the following drug is important?
Okay.
Liposomal amphotericin B therapy, fluconazole IV, voriconazole, ketoconazole, caspofungin.
Okay.
A,
So,
ma'am.
yes, very good. The answer is A. Why? Because the single drug of choice for mucormycosis is liposomal amphotericin B. All these are also your antifungals, right? So now can anyone elaborate me about your mucormycosis? What is mucormycosis?
Mucormycosis, it's invasive fungal infection. We have
Okay.
seen lots of patients during the COVID outbreak.
Okay, very good. So basically mucormycosis is a fungal infection. Yes.
It
It
causes
is due to the which fungus is there? Rhizopus. Yes,
Rhizopus
very good.
mucus.
So, mucorales or rhizopus is the fungus that is going to cause you mucormycosis. And this, there is going to be one simple terminology that you need to remember here. There is angio invasion of the fungus. When we say angio invasion, that is the blood vessels. This mucor fungus, it invades into the blood vessels and then causes its necrosis or its tissue ischemia, or then the disease is getting spread. So basically this fungus angio invasion of this mucor, it gets from the small capillaries and then it gets into the body. What all we see here? We see the black necrosis, which is an ideal characteristic of your mucormycosis. And most common risk factors for mucormycosis, first is going to be what? First is going to be your DKA or your diabetes mellitus, then your prolonged steroid therapy. Also, someone who's having neutropenia can get mucormycosis, and there is maybe iron overload, patient who is having too much of transfusion, blood transfusion, and sometimes patients who's already having HIV. So basically this mucor you do not see in common patients unless until the immunity is compromised. Neutropenia, steroid therapy, diabetes, iron overload, or post-cancer treatment patients, all these patients are more likely to get mucormycosis. When we talk about this mucormycosis, it is going to be spreading through the angio invasion, that is the small capillaries from the nose, from the eyes, or any small injury. Angio invasion of the fungus is going to take place. Okay. Does Candida or does Cryptococcus have angio invasion? Yes. Anyone? Does Candida or does Cryptococcus have angio invasion? No. This is only a property or a characteristics of your rhizopus. Okay. Now, the drug of choice here is liposomal amphotericin B. It is the first line most effective against the mucorales or rhizopus. Over the conventional amphotericin B that the regularly we use, this liposomal part, it is less nephrotoxic. Now, everyone knows in the exam, they always ask you what is the most common side effect of amphotericin B. It has to be nephrotoxicity. But if you give the liposomal part, then the nephrotoxicity is reduced by 30% due to the liposomal type of amphotericin B. Fluconazole, it is not active against what? It is not active against mucorales. Fluconazole can be given against what? Can anyone tell me?
Candida.
Very good. So, fluconazole can be given against Candida or Cryptococcus. Cryptococcus, again a systemic fungus, right? Voriconazole can be given against what? It can be given against aspergillosis. Voriconazole is a drug of choice for aspergillosis. Aspergillosis nigricans or plain aspergillosis. Then you have ketoconazole. Ketoconazole, it is used for what? Anyone?
Infection.
Yes, low grade systemic fungal infection. But it is not usually used these days. It is kind of absolute. Topically, at times it can be good, but it is not used these days because it has poor efficiency and high toxicity. Capsofungin, again, the drug of choice for Candida and your aspergillosis. Okay, so let us revise. If it is fluconazole, drug of choice is going to be for Candida and Cryptococcus. If it is voriconazole, it is used against aspergillosis. And if it is ketoconazole, low-grade systemic fungal infections. Capsofungin for Candida and aspergillosis. Is it clear? And one more thing, what I have not mentioned here, if it is a dermatophyte or a, okay, fine, dermatophyte, or you can say a skin fungal infection, what will be the drug of choice? This is the hint for you. Which is this antifungal? Terbinafine. Okay. So, terbinafine can be used for your dermatophytic type of infection. Clear? Is this antifungal part clear for all of you? Yes, today everyone is very lazy. What happened?
Yes, ma'am.
Yes, ma'am.
Yes.
Okay. Also, there are another type of drugs that you should be knowing, which is your posaconazole. This is also used very widely in the ICU or in your hospitals, multi-speciality hospitals. It can also be given as a oral maintenance therapy after your life amphotericin B. Okay, so posaconazole can be given for maintenance after the amphotericin B. Okay, so why amphotericin B? All right. Now, these are the 4 infections that we usually see, which is commonly asked in your exam. 1 minute. Just shift this out. Okay. Okay, so first we have mucormycosis, then we have aspergillosis, candida, and then we have the candida which is going into the bloodstream. Okay, so basically candida systemic one, mucormycosis, aspergillosis. Let us first confirm or pay attention to mucormycosis caused by rhizopus. Most commonly here you have the mucorales. Angio invasion is one of the main things that you should be knowing, which causes thrombus and tissue necrosis. Can anyone tell me what are the signs symptoms of mucormycosis? What are the signs symptoms for mucormycosis? Initial, the patient will come with what? With facial pain. Yes, facial pain. Then you will see black eschar. Black eschar where? On the nose, in the nasal cavity. Okay, so black eschar will be there in the nasal cavity. There will be also orbital swelling. I have written here orbital swelling. No, there will be orbital swelling. So these 3 complaints the patient will first and foremost come to you. What all? Facial pain, black eschar, and orbital swelling or periorbital edema. There is angioinvasion, tissue necrosis. Classic host will be your DKA, steroid, iron overload, or your post-malignancy or your HIV patient. Hallmark clue, He's a diabetic male, he's on steroids, or he has taken blood transfusion in the past. What will be the drug of choice? Liposomal amphotericin B, orally maintained on posaconazole later, once this treatment is over. Okay. Then coming for aspergillosis. Aspergillosis, what all do you see in aspergillosis? It is caused by the aspergillosis fumigatus. This is again a typical type of a septate hypofungi. There is angioinvasion in neutropenia only in immunocompromised patient. So only immunocompromised is going to get your aspergillosis. Aspergillosis pneumonia is very common among morbidly ill patients in the ICUs. Always remember that. And whenever you see aspergillosis, always your word or always your clue should be going for N. That is your neutropenia. Okay. Now in the lung, there will be nodules and cavitatory lesion. Also see here, this is the aspergillosis type of lesion that you will see. Cotton ball appearance here also. This is the aspergillosis lesion. Generally you see it as a halo sign or a air crescent sign. The drug of choice for aspergillosis, voriconazole. Now coming to candida. Candida can be of various form. It can be a topical candidiasis. It can be a systemic candidiasis. It is mainly caused by the yeast or a yeast-like fungi which has a pseudo hyphae. So basically whenever we see candida, it is going to be a yeast-like fungus which is not a typical fungus. So this is going to be the yeast-like budding appearance in candida that you will be having. So yeast-like fungus with pseudo hyphae. It can cause you bloodstream infection and biofilm formation. Bloodstream and biofilm where? In both the ICU type. Again comes for the biofilm formation. Last time I had mentioned. So can you tell me the places where biofilm is formed? Where is biofilm formed?
Central
Yes.
lines.
Central line in the catheter. Urinary catheters basically. Yes. Very good. And then this infection enters into the bloodstream, the kidneys, the livers, the eyes. In the See here, this is the CT scan picture. Here there is going to be multiple macro abscesses. So multiple macro abscesses will be formed inside the lung. The lung fields you are seeing here, that is the multiple micro abscesses are formed in severe systemic candidiasis. The drug of choice is going to be echinocandin or maybe your capsofungin. And do you need a surgery? No, we do not need a surgery for this. Surgery is only needed in one type of fungal infection, that is your mucormycosis. What surgery will be doing in mucormycosis? Anyone? What do we do in surgery in mucor?
Functional endoscopic.
Okay, we do FESS, right? So
Yes,
this
ma'am.
is your answer. Functional endoscopic sinus surgery. But what do we do in this? We do debridement. The wound debridement is done in this FESS. Okay.
Yes, ma'am.
Yes. So now this is how the mucor is going. See, the mucor comes in the form of spores under variable conditions, weak immune system like COVID-19. Then what? How does it affect? It goes into the brain and the sinuses with the help of angioinvasion that I was trying to tell you. This angioinvasion, this fungus, it enlarges itself on the iron that is inside the blood vessels. From here, it goes to the brain, it goes to lungs, it goes for non-specific sites, just like your liver, gallbladder maybe. It affects the bloodstream and then it affects the skin. So, one word, angioinvasion, always remember for your mucor. Okay, so we have just seen this all some time ago, but one more thing that I would like to explain here, amphotericin B, major side effect everyone knows, nephrotoxicity, hypokalemia, hypomagnesemia, fever and chills, sometimes shake and bake type of a appearance is seen in the patients. What all does it cause? Hypokalemia, hypomagnesemia, fever and chills. Okay. So the amphotericin B, more than its uses, you should be remembering its side effects. The side effects are more severe in amphotericin B as compared to other antifungals. Then you come for fluconazole. Fluconazole, what is it going to be? It is majorly going to be hepatotoxic or QT prolongation. Other drugs which cause QT prolongation, please tell me.
Azithromycin.
Actually,
Yes.
Dipyridamole.
Okay.
Moxifloxacin,
Okay. Very good. What else? Something which was used very initially in COVID, as you were talking about COVID.
Remdesivir.
remdesivir,
No, not remdesivir, but chloroquine. Okay,
chloroquine.
hydroxychloroquine.
Yeah,
Yeah, so chloroquine will be there. There will be lithium. 1 minute. There is lithium. There is chloroquine, which can cause prolonged QT. Then there is going to be even your basic everyday drug, that is ondansetron. You use it very commonly in the hospitals, but sometimes in some patients, ondansetron or domperidone can also cause you prolonged QT. Also, fluconazole, voriconazole, everyone knows. Azithromycin, then clarithromycin, and sometimes antiarrhythmic drug, that is procainamide, which is very common for your prolonged QT. Okay. Then you have voriconazole, drug of choice for aspergillosis. Sometimes can cause you ophthalmic symptoms. Don't use voriconazole for mucormycosis. Posaconazole, mucor step down therapy in neutropenia. So sometimes if the patient undergoes a surgery, was having amphotericin B, now he's going home. At the time of going home, what will you suggest him? You will give him posaconazole as a oral drug. Then you have ketoconazole, itraconazole. Itraconazole, again a drug of choice for your histoplasmosis. Can anyone tell me that histoplasmosis or blastomycosis is a topical fungal or is it a systemic fungal infection? Yes,
Systemic fungal infection.
very good. So it is a systemic fungal infection. Then you have what? You have your ketoconazole, which is rarely used, and the main part of ketoconazole, one of the drugs which causes you gynecomastia. Another two drugs which causes you gynecomastia, cimetidine and spironolactone. Along with that, you also have ketoconazole, which causes you gynecomastia. Then you have capsofungin. Where is capsofungin given? It is given in invasive candidiasis. Invasive candidiasis, capsofungin is given for, again, it has a poor CNS penetration. That is okay. Just remember, invasive candidiasis, capsofungin is given. What else do we have here? You have flucytosine, again given where flucytosine is a drug of choice for your cryptococcal meningitis. Clear? And terbinafine, as I told you, can be used in your dermatophytic infections. Okay, so I give you one question now. If there is a 45-year-old male, he has DKA and has micro abscess in lungs. What is the diagnosis and what is the drug of choice? Yes, please.
ma'am, it
think
should
it's
be micromyosis. It should be micromyosis. And the drug of choice is
Read the
liposomal.
question. Read the question properly, my dear.
Aspergillosis.
aspergillosis and drug of choice is voriconazole.
Why aspergillosis, Dr. Piyush?
It's
Ma'am,
causing the manifestation in
The
lungs.
ma'am, mine
especially in
is
lungs.
candidiasis.
And
Yes, Dr.
candidiasis.
Saranya, you said
Yes,
it
ma'am.
right. It is
Yes, ma'am.
microabscess in the lungs. That means it is candidiasis. And
Candidiasis.
yes,
The treatment
candidiasis,
is echinocandins,
capsofungin. Yes.
capsofungin.
Okay. And the next question, 55-year-old female has nasal HR. Diagnosis also, she has orbital pain. What will be the drug of choice? Dr. Rabia, here we'll be using the liposomal amphotericin B because now it is
Mucormycosis.
your mucormycosis.
Mucormycosis.
Yes.
Yeah, first I thought microabscess because of the microvessels or
Yes, yes. So I told you read the question properly. Dr. Piyush, now if I have to ask about aspergillosis, what should be my answer? What should be the CT scan finding in aspergillosis?
Cotton wool
It's
spots.
Yes, cotton wool or your transparent snow cloud appearance. Then what will be the drug of choice for aspergillosis?
Voriconazole.
Voriconazole. Very good. Now, if the patient has dermatophytes, drug of choice or skin fungal infection, you can call it as
Dermatillin.
Terbinafine.
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 Dermatillin.
Yes, terbinafine. Okay, now a bit of complex question. If a patient, he has what you can say prolonged QT and even hepatotoxicity, what will be the causative fungal agent? Tell me.
Fluconazole.
Very good. So it can be fluconazole because fluconazole causes prolonged QT with hepatotoxicity. Is all antifungals clear for you?
Yes, ma'am.
Any doubts in antifungals or mucormycosis? Any question now, I guess, on antifungals? If it is coming, then you can answer it properly, right? So just like we said, fluconazole, it has hepatotoxicity and prolonged QT. Okay? Fine. Any doubts in antifungals? Yes, students. Okay. Someone has some doubt? 1 minute. Okay, no.
In
Okay,
progress.
so now next question. Can anyone read out this?
32-year-old sportsman who recently attended a wild game feed banquet consumed summer sausage made from bear meat. He complains of abdominal discomforts, diarrhea, and muscle tenderness. Most likely diagnosis is option A, trichinosis, option B, salmonellosis, option C, giardiasis, option D, escheriasis, or option E, shigellosis.
Okay, so can anyone tell me what is your answers?
It is
You can
A.
post it in the group also. Okay, everyone's saying A, that is, it is trichinosis. Why? Dr. Rabia, can you explain me?
Ma'am, because he eat uncooked meat.
Hmm.
The sausage is beds by most of the time causing the disinfection, trichinosis.
Okay, trichinosis. What is the causative organism for trichinosis?
Trichinella spiralis.
Yes.
Trichinella, right. It is Trichinella. Fine. All good. Now let us see exactly what happens in this trichinosis or Trichinella. Here, whenever this undercooked meat, okay, so when the patient is consuming the undercooked meat, what is happening? This undercooked meat, it has a encysted larvae. Okay, so encysted larvae, that is the smaller form of the worm is already there. This encysted larvae, what does it do? It goes into the intestine. Now, in the intestine, this larvae then migrates from the bloodstream. So basically, it goes into the intestine, it gets developed out there, and then it goes into the blood. Because this larvae loves nutrition, it loves blood, it can also invade into the skeletal muscle. Okay, this larvae also invades into the skeletal muscle, which in return causes you myalgia or your skeletal muscle tenderness. Why does it go into the skeletal muscle? Because it loves vascularity and skeletal muscles are highly vascular. The larvae will migrate to the skeletal muscle. Now, when we talk about trichinosis, this trichinosis comes in two stages. One stage, it has to be your early stage of your abdominal pain. Okay, so whenever this type of a patient is coming, this abdominal phase, this has to be your phase 1, abdominal pain 1. Here, what all things will be having? He'll be having nausea, diarrhea, vomiting. So, this is the reason for the muscle tenderness. Then, diarrhea and abdominal discomfort. So, this is your stage 1. After that, when this goes down, when it goes into the stage 2, here your muscle involvement will be there. Along with that, there will be eosinophilia. Sometimes they ask you that what one parameter that is raised that you will see on the CBC, that has to be your eosinophilia. Then there will be fever. Fever is never in the first initial stages. Also, at times there will be your periorbital edema. Okay, so just remember the pathophysiology and the course of this disease. First, what happens? The undercooked meat you eat, the larvae is encysted. That is, it is inside a capsule. So supposedly this is a capsule, this is a larvae. It goes into the intestine, and in the intestine it becomes a normal larvae. Now this takes place, it gets migrated and it goes into your skeletal muscle. So supposedly this is your muscle. This larvae is going to come and sit here. So after that, that is going to cause you myalgia or it is going to cause you muscle tenderness. So any GI symptoms, simple as that, any GI symptoms with your muscle tenderness, compulsorily the answer will be trichinella unless until any direct clue is given. Okay, is it clear? Yes, are you understanding?
Yes, ma'am.
Yes, ma'am.
Yes, madam.
Yes, ma'am. Perfect.
Okay. So after this, now as the same thing they have told here, when they say a wild meat party, wild meat is going to be wild boar, wild bear meat, undercooked pork. So basically, after hunting, whatever the wild meat is there, that party is called a wild meat party. Now my next question to all of you, how do you test the muscle inflammation or the muscle tenderness? How do you diagnose this clinically? Clinically, that is, you touch the patient is going to show you pain. But with the blood parameters, what blood test will you do for this?
TPK level,
Yes, you will do CKMB and you will do
CKMM,
LDH. Okay.
CKMM level.
And then you will do your muscle biopsy. Muscle biopsy, what will you see? It is not usually
Yes.
done, but it is a very definitive treatment. Definitive diagnosis. On muscle biopsy, you will directly find a larvae. Okay.
Larvae.
Yeah. So, why not other answers? That is okay. Now let us see lot of confusions with the foodborne diseases that people are having and what it is exactly causing. Before that, let me show you a small table. For example, now we have seen what it was, trichinosis. Where is this pen gone? Right? Okay, I got it. So if it was again a pork, okay, pork, it is going to cause you tinea. What will be the key feature that you will be seeing? There will be a intestinal tapeworm. Any infection with the tapeworm has to be your tinea solium or tinea saginata. Okay. After that, if you talk about salmonella, salmonella has to be what? Salmonella can be caused by your eggs or your poultry, chicken basically. And here you are going to have symptoms of acute gastroenteritis. And how is Giardia spread? Anyone? Giardia is what? Is it a parasite or is it what?
Parasites.
Okay. What is amoeba then?
Amoeba is also parasite.
So parasites.
Okay. So they belong to the same family, Giardia and amoeba. It is going to be spreading through what? Food or water?
Water.
Yes, it is going to be spreading through water. And one common characteristic is fatty diarrhea or steatorrhea diarrhea will be characteristics of giardia. Okay. Now let us see the table which is showing you all this. One is your salmonellosis. Now salmonellosis basically is caused by what? It is caused by your cooked meat, your sausages and your eggs and your chicken, undercooked poultry and eggs. Now what happens in undercooked chicken or eggs, or sometimes if the food that is getting contaminated with you can say some kind of a avian flu or some kind of any chicken has the poultry chicken has the infection, then also you can get salmonella. Also there is sometimes that the patients are having contact with the pet reptiles, or they are having some type of chameleon at their home, or they are going to the zoo to they have adopted some animals in the zoo, they are going to the zoo to take care of those animals. Such times also salmonella can be one of the causes, that is the disease can be salmonella. Why? Because the superficial skin of the chameleon or the reptiles or maybe some crocodiles that people are working in this veterinary farms or zoos, they have this salmonella on their surface area. For this, what will be the treatment? Salmonella, what will be the treatment?
Causes acute gastroenteritis. So treatment is rehydration.
Rehydration, as well as you can give doxycycline and azithromycin. Azithromycin 1 gram or doxycycline 100 milligram. Okay. And rehydration with ORS. Now coming to botulinism. Botulinism can also be caused by can also be causing you gastric symptoms or the food-borne diseases. Where does this botulinism come from? It can be coming from the canned food, the smoked fish, or your homemade sausages. Now, sometimes this botulinism is very common in people in Japan because majority of the time they eat smoked fish, or anyone who's having majority of the time canned foods. This is the causative for your botulinism. Now, why is this botulinism happening? This botulin toxin, it gets ingested via the food oral route. It affects your intestine and it causes necrosis in the intestine. So it is kind of lethal. You cannot just give the patient a OPD basis treatment. Any patient comes to you with botulinum toxin ingestion, always give him a ICU admission. Okay. Along with that, what will be the other symptoms? There will be diplopia, dysphagia, diarrhea, and bloody stools. So therefore, admit the patient in ICU when there is a botulinum toxin case. Now, coming for trichinosis, like we had it here, our patient. There is this wild meat. It is coming from undercooked pork, bear, or any wild games. So, what is the causative organism? Trichinosis spiralia. Undercooked wild meat causes trichinella, and the drug of choice is albendazole or maybe mebendazole. Both the drugs you can give here. Albendazole as well as mebendazole. Now, coming to tinea solium or tinea saginata from the beef and the pork. Both the places it is going. If it is pork, it is solium. If it is beef, it is saginata. Okay. And the drug of choice for this is praziquantel. If it is saginata, that is from the beef, and solium, tell me one place where it goes and enlodges itself and which causes you CNS symptoms.
I.
Yes, in the eyes, in the lungs, as well as in the brain. Tinea saginata can have lesions in the brain as well. Okay, so always remember it causes the lesions in the eye, in the brain, and in the lungs. Now, talking about giardia. Giardia is a basically, yes.
Ma'am, I have a doubt, ma'am.
Okay.
Then the condition neurocysticercosis is caused by tinea, right, ma'am?
Yes.
Okay, ma'am.
Yes. So, coming to giardia, that is always remember water because it can be a swimmer's disease or someone who's going and swimming in the rivers, in the countryside, or maybe in the raw waters. Untreated water, not swimming pool, but untreated water can be your giardia. It can be caused by drinking untreated stream water, contaminated daycare, What will be the drug of choice for giardia? Metronidazole. Okay. Clear? Are the foodborne infections clear for all of you?
Yes, ma'am.
Okay. So now let us revise it with the 3 questions. If there is a 35-year-old male who is a hunter by profession and he has abdominal pain with muscle weakness, what is he having? Yes, answers.
Vaginosis.
Stenosis.
Okay, very good. And what will be the drug of choice?
Albendazole.
Albendazole.
Liposomal infotocin.
Yes, Dr. Ramya. Come ahead from the next question, my dear.
Albendazole.
Okay, very good. Albendazole or mebendazole.
Yes.
10-year-old guy who goes for camping comes with acute gastroenteritis and he has diarrhea. What is the disease?
Salmonella.
Salmonella.
No. Why salmonella? 10-year-old boy who's going to camping. Camping means?
Giardia.
Giardiasis.
Yes, giardiasis.
Giardiasis.
Yes, so
Giardiasis.
giardiasis, right. What will be the drug of choice?
Metronidazole.
Metronidazole.
Very good. And now next question. A 60-year-old man who consumed pork has CNS symptoms, has epilepsy, has again dementia. What can be the possible lesion? CT shows brain lesion. What can it be?
Tinea.
Tinea.
Infection.
Yes, tinea, right. So what will be the drug of choice for tinea?
Praziquantel.
Very good. So it has to be
Steroids.
praziquantel. Steroids later. First praziquantel. Okay.
Yes, ma'am.
Is this clarified now?
Yes, ma'am.
Okay. One more question. If there is what you say, 29-year-old boy who has frequent history of junk and processed food, comes to you with a complaint of diplopia and diarrhea with blood. What is this?
Botulinism.
Very good. Why botulinism?
Because of the symptoms like diplopia and diarrhea with blood.
Diplopia, diarrhea with blood, and he's eating junk processed food. That means
Junk.
most likely to eat canned foods, right?
Yes, ma'am.
What will be the next management here?
ICU.
ICU.
ICU. ICU admission. Very good. Okay, next question. Scarlet fever is caused by, very simple.
Pyogens.
Streptococcus pyogens.
Yes, Streptococcus pyogens, but which group?
Group B.
Group A beta hemolytic streptococcus.
Very good. So it is group A beta hemolytic streptococcus. Now, scarlet fever sometimes can have the toxins which are produced. What type of toxins does scarlet fever produce? What is the name of the toxin produced by the beta hemolytic streptococcus? The word itself tells you which one? Yes, Dr. Piyush?
It's exotoxin. No?
Yes, it is erythrogenic exotoxin. Okay, so sometimes they ask you single liner question. Beta hemolytic streptococcus causes which toxin, releases which toxin? So it is erythrogenic exotoxin, or it is also called as pyrotoxin. Because it causes fever, it is pyrotoxin. Okay. Now, this is gram positive or this is gram negative?
It's gram positive.
Okay. Now,
Gram
someone
positive.
tell me what are the phases of your scarlet fever? What all do you know in scarlet fever? In phase 1, that is your initial phase, what all will you see in the patient? What symptoms will he complain? First, the fever, no doubt. Uske baad, he'll
Fever,
Sore
complain
throat.
rash,
sore
rash,
throat. Very good. He's going to complain
strawberry
sore
leaves,
throat, pharyngitis or tonsillitis, right?
sandpaper rash,
Very good. Tonsillitis or pharyngitis and sandpaper rash. But sandpaper rash will come in the second stage, my dear. Okay. First is your fever with respiratory symptom. Second phase is going to be your sandpaper
Throat.
rash. Yes. Second is your
Oh,
sandpaper rash. Also, this sandpaper rash, it can cause you pastia
strawberry
lines.
tongue.
Do you know what is pastia lines?
Yes, ma'am. It's rash around inguinal region and axillary region.
Yes, so something which is there between the skin folds. Okay, so this rashes, the sandpaper rash, it gets accelerated or it gets accentuated between your skin folds, and then we call it as pastia lines. Also, there is going to be the third stage, it is going to have your tongue findings. That is your strawberry tongue, which is a classical feature of your scarlet fever. Okay, is this clear?
It's
Okay. Now,
yes,
this
ma'am.
scarlet fever has a lot of differential diagnosis with your Kawasaki disease, with your measles, or with your toxic shock syndrome. So, this we know, what was it? So, this is your strawberry tongue that you see. Okay, we already have less time. Okay, let me just show you this. Now, the scarlet fever has differentials with your toxic shock syndrome, your Kawasaki's, or your measles. Now, scarlet fever is caused by group A streptococcus, causing you sandpaper rash. Toxic shock syndrome causes by Staph aureus, and it has hypotension plus multiple organ failure. That is, the patient is going to go into sepsis. So, hypotension with multiple organ failure. Kawasaki's disease is going to be a one vasculitis type of disease, which is going to have your fever as well as mucosal changes. And measles will have virus plus Koplik spots. Where is Koplik spots seen? On the skin, on the eyes, on the mouth, or on the
Buccal
nose?
mucosa.
inside the
Mouth.
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 Very good. So Koplik spots will be seen in the mouth. See here, this is the main thing that we see. Scarlet fever, it is going to have a sandpaper rash, a strawberry tongue, then a toxin. Then Kawasaki disease is there. Kawasaki's, the fever is going to be more than 5 days, and the patient is going to come to you with conjunctivitis, rashes, adenopathy, strawberry tongue, hand and foot changes. So always remember, crash is the mnemonic plus burn. Burn is your fever. Okay. Then you have your toxic shock syndrome, your sudden high fever, hypotension. Please mute your mic. Hypotension, diffuse rashes, multiple organ involvement. This all is seen in the toxic shock syndrome caused by what? What is the causative agent for this?
Staph aureus.
Yes, so it is Staph aureus. Measles, 3 C's, coryza, cough, and conjunctivitis. Koplik spots are pathognomic seen in the oral cavity. And rashes first start in the hairline, then come to the face, and then can go to the neck and the trunk. What vaccine do we give for measles? Combined with what?
MMR.
Vaccine.
Okay, MMR or MR vaccine. Is it a live or a killed vaccine?
Live
Live
vaccine.
vaccine. Live.
Very good. And always accompanied with what?
Rubella.
No.
So,
Vaccine plus
Sterile
what?
water. Powder plus sterile water.
You give MMR plus vitamin A.
Vitamin.
Okay. Yes. So vitamin A is always given in combination with your MMR vaccine. Okay. So I guess we'll take for more 3 minutes. Post-exposure prophylaxis in a dog bite. What will be the answer for this? What is the
Won't
PEP
get.
for rabies?
Won't get.
Okay. After that,
Progress.
All of the above.
All of
so the
them.
answer is yes. The answer is all of the above because we'll do first wound care, after that active immunization, after that passive immunization. Now let us not waste time and go to the main chat that we have made out here. Okay. So I'll just explain this quickly within 2 to 3 minutes. So then Dr. Ramya can take your session ahead. Okay, so when we talk about the category of the dog bite or any mammal bite, basically rabies. So what are the categories? Category 1, 2, 3 and 3, 2. Okay, so category 1, what is category 1? It is nothing but it is only skin breach. That is only touching or feeding animals. Basically any, if you have a pet at home and the pet is harmless, it is not causing you any bites or is not playing with you very harshly, it's only touching and feeding animals and licking of intact skin. That is your category 1. What will you do here? You are not going to give any vaccine at this time. Okay, you don't need to give any vaccine out here. Category 2, it is a minor exposure. That is the cat or the dog, it is simply scratching you very gently without bleeding. The main part you should remember here is without bleeding. Here you will take rabies vaccine and here you are going to wash the wound. Always remember in rabies, how much ever higher the wound is, never do packing of the wound. Never do dressing and packing of the wound. Always wash it with soap and water, running water for 5 to 10 minutes or 15 minutes you can say, and just keep the wound open. Keeping the wound closed, it is going to cause this rabies virus to enlarge into the nerve endings and then progress to the disease. Okay. Coming to category 3, that is your severe exposure or your transdermal wound, you can say. Here there is going to be multiple bites with bleeding and there is going to be saliva mucosa licks on the broken skin. Here you do not need rapid immunoglobulin or rabies immunoglobulin infiltrated into the wound, but you can give the patient vaccine and wound washing is also recommended here. This is the third B category, which is a severe case. That means any stray dog, it is biting the patient very badly. There is going to be scratches, bleeding, bites, everything. But here, what you're going to give, here your rabies immunoglobulin is needed. In category 3, rabies immunoglobulin is needed. Even your vaccine is needed. And even your wound care, wound wash is needed. Okay, so all the things you will be giving in category 3. Category 2, only two things. One is rabies vaccine and wound wash. Category 1, no vaccine, no immunoglobulin, just wound washing or just washing of your hand. There is no wound basically, so just wash your hands properly. Now, when we talk about the rabies vaccine, there is two schedules for this rabies vaccine. One is the intramuscular and one is the intradermal. Remember the names. The intramuscular, it is called as the Eisen regime and intradermal is the Thai regime. Intramuscular, we give 0, 3, 7, 14, 28 days. But intradermal, which is a Thai regime, we give 0, 3, 7, 28 days. 14 days is missing out here. And both the sides, like right arm and left arm, we give both the sides the injection. So supposedly if the patient is coming on day 0, give him in the left and right arm both intradermal injections. Okay. Then day 0 always is the first dose day. That is not the day of the bite. So do not calculate that ways. That okay, the bite was there 2 days ago. So day 0 is already gone. No. Day 0 is when the patient comes to you and first time when you see the wound. That is your day 0. Now these are the names of the rabies immunoglobulin. Rabies immunoglobulin. Okay. Giving rabies immunoglobulin after 7 days of vaccine. No, not recommended. Small scratch. Category 2. And immediate wound suturing, never recommended. So always remember, never suture, never pack, never do dressing with a closed environment for your rabies wounds. Rabies wounds needs to be washed with plain soap and water, running water for 15 minutes, 10 minutes. Okay. Also later on you can put some betadine, that is a povidone iodine into that. That should be sufficient for your wound care of your regime. That is category 2 or category 3A. Is it clear? Is rabies clear for all of you students?
Yes, sir. Yes, sir.
Okay, so I'll be handing over to Dr. Ramya now because it's already 2:15. Ramya ma'am, are you there?
Yeah, dear, I'll take over.
Yes, I'll just make you the host, ma'am.
Mhm.
Okay. Thank you, everybody. Thank you for paying attention. I hope it was an informative class for you.
Thank you, ma'am. It
Thank you,
was a
ma'am.
different class and very informative.
Very
Yes.
interesting today.
Yes, it was all infectious diseases. Although we had one question, we covered a lot of points in those one question with the help of differentials. Okay. Please study well.
Thank you.
Thank you, ma'am.
So good afternoon, girls and boys. Tired?
Good afternoon, ma'am.
Good afternoon, ma'am.
Are you ready? We'll start or we want some chatting?
No, we will
You
start.
want sleeping?
Recording in progress.
Okay. So today we'll be as in the previous class we were thinking that for every question, if I give some more explanation, I think they told it would be better. So my today class will be in that way. Like I have chosen two, three topics for today, and we will be just discussing the questions. This is just to tell you that, see, in our regular classes, what we are taking in this way, topic wise, because topic wise would be more like you have more consistency with your knowledge, and you can expect what are the different types of questions that can be given in the same topic. And even if they twist or even if they do something like they try to confuse you, if I'm creating your basic knowledge, like your basement, foundation is good, then obviously you can rock any twists in the question or any sorts of confusion. So today my class pattern is a bit different. So once the class is done, let me know how this, like, is this is good or the previous one is good, which one to follow. Am I clear? So I think this question was discussed previously also. So any one of you can take this question, Mifra.
Yes, ma'am. A woman with a severe dysmenorrhea, dyspareunia, infertility,
Recording in
best first-line medical treatment. As infertile, I will ignore the surgery and combined OCP. Left with GnRH agonist. I will go with
I will go with combined OCP.
Okay. Rest of the people, if I'm asking to Mifra the question, rest of the people can put in the chat box what is your answer. No worries. Now Rabia told because I think Mifra went into mute. So what is your answer, Rabia?
Ma'am, combined OCPs.
Yeah, here I think this question was discussed previously. That's why I wanted to just
you
boost up that
taught
because
us.
it was like GnRH agonist, which means it will completely cause a medical menopause. So that's why a person who is planning for infertility, we will not go with the GnRH agonist. As surgery also, we'll try to, because if you do surgery, we'll just manipulate our, like more manipulation with the ovarian like tissue. We might apply cautery, which might further reduce the ovarian pool, okay, ovarian follicle pool. So that's why better option would be temporarily for OC pills. For sure, infertility as of when you give temporary OC pills, that time she will be infertile. But once you stop OC pills, there will be return of fertility in a better way. Am I clear? So now the next question will be now. So first my topic is AUB. Okay. Now I'll be telling few questions on AUB. Then we'll be discussing actually what is AUB. Previously this was called as DUB. Okay. Now the term has been changed to abnormal uterine bleeding. So everyone please mute except the one who is reading the question. Sandhya?
Yes, ma'am.
You read the question.
Yeah, this is 45-year-old.
Yeah.
heavy bleeding and fibroids, what will be the first investigation? MRI, agricultural endometrial biopsy.
Yeah.
So basically, she's 45-year-old and she has a heavy bleeding and there are fibroids. So we have to tell what will be the investigation. First investigation, we will do to diagnose the patient. So I will say C, ma'am. It is pelvic ultrasound.
Wonderful, dear. Any other opinion?
First investigation is pelvic ultrasound, but the best investigation is endometrial biopsy.
Yeah. So see here the question they
Ma'am, in
asked.
fibroid we can do endometrial biopsy.
Let me tell you. Okay. So the patient has come with AUB. Like this is abnormal uterine bleeding. So what is abnormal uterine bleeding? So abnormal uterine bleeding is nothing but when any lady in the reproductive age group, okay, has bleeding which is excessive in amount for prolonged duration and a frequency is more frequent. Am I clear? So this comes under abnormal uterine bleeding. And this abnormal uterine bleeding has been classified into two reasons. It can be a structural cause which is seen on imaging or histopathology. For example, like uterine fibroids. Okay. Sometimes it is not visible on imaging, or even if you do pelvic examination, the pelvic examination uterus will be of normal size. You got it? So, based on whether it's a structural cause or whether it's a non-structural cause, we divide the AUB, we classify it into palm, coin. Just remember like your palm and a coin, 1 rupee coin. So, what is P? P is any polypoidal growth. A is any adenomyosis. L is leiomyoma, that is also known as fibroid. M is any malignancy. Okay. And coming to the coin, which is nothing but there is no visible abnormality on imaging or on pelvic examination. Everything is fine. But why the bleeding is? Because the patient is having some coagulation abnormality. That might be like from childhood onwards, any platelet dysfunction or like hemophilias. Okay. So any coagulation abnormalities. O is anovulatory, which is the most common cause, like PCOS, where there is hormonal imbalance, the ovulation is not happening. That is O. E is endometrial cause. This E will be the cause if everything is ruled out. Like you ruled out there is no coagulation abnormality, you ruled out scan, there is no ovulation in like anovulatory cycles. And what is I? I is iatrogenic. If the patient is on warfarin, on heparin, obviously the patient will be having iatrogenic cause. And N is, if not coming to any other category, will go into non-specified. So here coming to E is endometrial cause is diagnosis of exclusion, because you know in every menstrual cycle, okay, in every menstrual cycle there are certain changes that happen in the endometrium. That is the prostaglandins ratio. There will be increase in the prostaglandins which will cause vasoconstriction and decrease in the ratio of vasodilators. Because of this vasoconstrictors high level, the endometrium starts shedding. So when there is abnormality between these two prostaglandins, that causes this sort of AUBE. How will you differentiate between ovulatory cause and endometrial cause? If anovulation occurs, the cycles will be regular or irregular?
Irregular.
Yeah. So if irregular cycles they are mentioning, and then they are telling the irregular cycles with heavy flow, then your first DD will be ovulatory cause. If they tell cycles are very regular, but there is heavy flow with passage of clots. What is the significance of clot passages? Usually normal menstrual blood will not clot unless until it is heavy than the usual. So whenever any question tells that it's clotting is there, that means it is something abnormal and it will come under E. Am I clear? If the patient is on anticoagulants like heparin, warfarin, then the AUB will be iatrogenic. If nothing is known, what is this? We'll go into If nothing is known, then we will classify that into as N, not specified. We don't know what it is. Okay. Now you can go with so what she told is correct. Here a patient with heavy bleeding, a fibroid. If the fibroid is there, the best and first investigation of choice would be, initial investigation of choice would be pelvic ultrasound, in which you will know what is the fibroid size. Usually when these fibroids are there is association with endometrial hyperplasia, that is thickness of the endometrium, especially if the woman age is above 45. So you should assess the endometrial thickness, and if the thickness is more than the usual, then endometrial biopsy is essential as a part to rule out endometrial hyperplasia. Okay. In the same question, if they are telling multiple fibroids, nulliparous lady, what is the best investigation of choice to assess the exact fibroids? Then the answer would be
CT scan.
CT scan? What do you feel? CT scan or MRI? For fibroid mapping. See, now one more thing, the fibroids are of different position. Like see, this is which is completely outside is known as subserous. The one which is intramural, this is intramural. And the one which is close to the endometrium, this is known as submucous.
Mucus.
Okay. There was one question recently I heard. What is the most common type of fibroids that is seen? See, usually this FIGO classification, FIGO has been classified the fibroids into different types according to the location. Okay, like submucous, intramural, subserous, and also they have been like, see, FIGO classification, if it is 0, that means it is completely submucous. Okay, if it is type 1, that is it is intramural, also like more into the submucous component. Like that, this comes from outside, like it goes to outside. If it is completely intramural, the FIGO stage is 4. And the last one is like subserous, that will be of 6 or 7. Okay, 8 is parasitic fibroids. Like parasite means it might be in the cervix, it might be in the ovary, because anywhere you can see fibroid. And recent question was the most common type of fibroid seen in reproductive age group is intramural. This is the most common type of fibroid that is seen. This is a recent question. One of my friend told me. So why it is important? Because this subserous, it will not cause much symptoms because it is outside the uterus. Because of the big size, it might cause pain, or maybe it might compress the ureter and might cause some urinary retention or urinary problems. Intramural, because the size is more, or the submucous is towards the cavity. Submucous will have, when you have menstrual bleeding, obviously these fibroids are exposed. So these patients will present with AUB, and also if they are trying for pregnancy, the submucous fibroid will also cause infertility. So they present with infertility. The most common one is intramural. These intramural fibroids, they present with AUB. They have abnormal uterine bleeding, and when we check, so it is intramural means it is located within the myometrium. Submucous means it is projecting into the uterine cavity. Subserous is it is projecting away, so into the peritoneal cavity. And if these are all sessile, if it gets one stalk and then it is like this is pedunculated fibroids. Am I clear?
Yes.
So it's very important to know about the fibroid, what type of fibroid it is and what symptom it is causing. So here, initial investigation, obviously the first investigation of choice would be pelvic ultrasound. But if they're asking what is the best investigation to assess the fibroid mapping, that is MRI. MRI will give you exactly the number of fibroids, the location of fibroids, size of fibroids, and the feasibility of surgery. Like if I wanted to plan for a myomectomy, so like where can I put my incisions? So that's why in the same question, they can ask differently. Here the question asked is, what is a first investigation? But the first investigation would be a pelvic ultrasound. Am I clear? Now coming to the next question, who is going to read next question? So palm coin classification, fibroid falls under which category? Rabia.
Ma'am, I don't know about it.
Hey, now only I explained you na. Palm coin. P is polyp, A is adenomyosis, L is leiomyoma, M is malignancy. So now fibroid comes under which category? AUB-O, AUB-L, AUB-E, AUB-C.
Ma'am, then AUBL. L. E. L. Leo.
So AUB-O means anovulatory. That means PCOS. AUB-E means endometrial cause. Like if any abnormality in the prostaglandin ratio, then it will be AUB-E. AUB-C, if the patient is having hemophilia or if the patient is having some platelet dysfunction disorder, then it will be AUB-C. Am I clear? So this palm coin classification is very important. Just go through it. That's why today I have put like about the topic. I have come with the topic wise treatment. Okay. Now, the next question. Who is this Nazar Latif? Is he free? He can read? He or she? I'm sorry. Next one, who is going to read the question? Dr. Aknkssha?
Yes, ma'am.
Read this question.
Acute heavy bleeding, hemodynamically stable. First medical treatment is tranexamic acid, hysterectomy, misoprostol, or copper IUD.
Yeah, what is your option here? Acute heavy bleeding, hemodynamically stable.
Is A, tranexamic acid.
Perfect. So first, in all questions, just keep in a mind, if the patient is hemodynamically stable, that means you can go with the general OPD type of management. If the patient is hemodynamically unstable, shock, or the patient's vitals are less, in whatever question it is, first resuscitative measures, then go with the direct appropriate measure like surgical management. Don't waste your time doing scan, doing like blood test, nothing. So here, the patient is having acute bleeding, but the patient is hemodynamically stable. That means you can give OPD management. So what is the first initial management for any patient who comes with bleeding? It's tranexamic acid. What is tranexamic acid? It's an antifibrinolytic agent which is given to reduce the bleeding. And one more thing that you have to remember is any abnormal bleeding which is occurring between 45, like above 45 years, it can be because of hormonal fluctuations or might be because of any structural pathology like abnormalities like fibroid. But obviously above 40 years or 45 years, especially you have to do an endometrial biopsy to rule out any malignancy in the endometrium. For a stable patient, medical therapy is best. However, hysterectomy would be definitive treatment if the patient has completed the family and the patient is telling I have severe symptoms. Now, I think Rabia, you were telling, right? You have no idea about palm coin. See this. So, first one, as I told, you should always remember this AUB classification with two things. One is you remember palm, your palm, and the second is coin. So in the palm, it is all structural complications, like structural problems. Like see, it's a polyp. It's a polypoidal growth which can be erased from the endometrium or from the cervix. So any polyp, what it is, it's a structural growth. So usually what they present, If the polyp is outside like this, lying outside, when you are doing any heavy work or something like that, you will have intermenstrual spotting. That is a significant history that a patient tell. If a patient tell that she is having intermenstrual spotting with maybe heavy flow at the time of period, always rule out a polypoidal growth. Do a scan first, and if the scan is showing some growth, go with hysteroscopy, because where you can put a camera inside the uterus, see the polyp, and also treat at the same time. Am I clear? Second
Yes,
one, A, is adenomyosis. Adenomyosis is also a structural abnormality where usually the endometrium, usually the endometrium will be lying over like inside, right? Here endometrium. So every time when you get periods, you get bleeding only from inside. But whenever this endometrium lies in between the myometrium layers, and whenever it starts bleeding and this also starts bleeding, this forms adenomyosis, and slowly over a period of time it will form a mass inside the uterus. This is known as adenomyosis. This adenomyosis will cause dysmenorrhea, dyspareunia, bulky sized uterus. So what is that investigation of choice? You do scan, you find out that it's adenomyosis. To confirm, you do MRI. Am I clear?
Yes,
And
ma'am.
the third one is PAL, palm. Structural abnormalities where you have big fibroids, which might be present subserous, intramural, sometimes submucous. So these fibroids will cause heavy bleeding, and when you check the size of the uterus, it will be multiple like this. See, enlarged, lobulated, multiple irregular uterus. Okay, the first investigation of choice is ultrasound. If you want to do fibroid mapping, then again go with MRI. Okay, the fourth one is malignancy, which is a structural abnormality. So any hyperplasia, malignancy, any patient more than 40 years, heavy menstrual bleeding, check the endometrial thickness, assess the endometrium, go for endometrial biopsy. Even if it is a postmenopausal lady bleeding, you have to go with an endometrial biopsy. So these are all about palm. Got it? Palm means only structural abnormalities. Now coming to the coin. What is C? C is coagulation abnormality. That is coagulopathy. That is non-structural. See, if this coagulopathy should be reason non-structural, will it be suddenly appearing at 40 years? No, right? Because the patient has this coagulation abnormality since menarche. So they will have symptoms since menarche. Along with these, the patient will tell that whenever I brush my teeth, there will be bleeding, there is history of epistaxis, there is easy bruising, wound will not be healing properly, I have lot of bleeding. Then the best investigation of choice is to assess the coagulation profile, rule out which coagulation abnormality is found. So these are non-structural. Second one is ovulation dysfunction, that is irregular cycles. I was telling you multiple times, irregular means anovulatory. PCOS is the most common cause. How you go with this? Clinical and hormonal testing like FSH, LH, and all those things can be checked to assess the irregularity. Endometrial is also non-structural. It will cause regular heavy bleeding, not irregular, regular heavy bleeding. And on scan, everything will be normal. This E will come as a diagnosis of exclusion. Like you have done everything, no, then you think of endometrium. Directly, you cannot tell that it's endometrium. You got me? And last is iatrogenic. You have to ask about the drug history. You ask about the patient whether she is taking OC pills, any copper coil inside, any anticoagulants, then that will come as iatrogenic. Not yet classified is the last one, rare causes. Very rare causes where a specialist evaluation is required. Am I clear?
Yes, ma'am.
Girls, this is very important. And now most of the questions will come with AUB. AUB is like, because see, like evolving topic now. So that's why you should know what category a patient who comes with AUB will set into this. Now, coming to the question, patient is hemodynamically stable, medical management, first line tranexamic acid. If it is mild to moderate, you can give oral Tranexxa. If it is severe, you can give IV Tranexxa. If still the patient is bleeding, you can go with either high dose of progesterones or high dose of combined OC pills. Okay? If the hemoglobin, here the hemoglobin not mentioned, but if they mention hemoglobin less than 7, blood transfusion is required. Surgical intervention is required if the patient is hemodynamically unstable, tachycardia, HB less than 7, emergency hysterectomy as a last resort to save the life of the patient. You can even think of this uterine artery embolization. Do you know what is embolization, uterine artery embolization? Mifra, any idea what is uterine artery embolization? Piyush,
Ma'am,
Sharanya,
I have some idea.
what is that?
Yes, ma'am.
They go by the cath lab, by the femoral, and embolize the uterine artery to reduce this blood supply of this fibroid.
Yeah. So it's very simple, dear. Where this is a uterus. So through uterine arteries, you are having heavy bleeding, right? So and multiple fibroids. So a patient who is not willing for any surgery, you can just knock down the uterine arteries and reduce the blood supply so that the bleeding will be reduced. This is uterine artery embolization. It is done when the patient is not willing for any surgical management. Then usually we go with that. Okay. In selected cases, we
Yes,
do.
ma'am.
Okay. And Sharanya, read this question.
A 42-year-old Gravida 3 Parity 3 woman presents with heavy menstrual bleeding for 8 months, passing clots, changing pads every 1 to 2 hours on a day 1 to 2. She has fatigue and dysmenorrhea, no intermenstrual bleeding. Ultrasound shows single intramural fibroid 4 centimeter, normal endometrium, no adnexal mass, and hemoglobin is 9.2 gram per deciliter. She does not desire future fertility. What is the most appropriate initial management?
So now you tell me, Sharanya, what I told you understood, then you should answer this question. So what would be your appropriate initial management? Is the patient hemodynamically stable?
Yes, ma'am. She's hemodynamically stable.
So now what you will do?
But she's feeling fatigue and dysmenorrhea, so I don't know about the hemodynamically stable part.
See, now what is the question asked?
She does not desire future
appropriate initial management.
Okay,
Medical
Initial management would be what, dear? Can you do
medical
hysterectomy?
management, ma'am.
Simple thing. If
Yes,
they skipped out this initial, what is the most appropriate management? That would be not immediate, but hysterectomy.
Okay, ma'am.
You got it. Here they are asking initial and they have given immediate. So immediate cannot be done. So initial will always be a medical management if patient is hemodynamically stable. This patient is hemodynamically stable, right?
Yes,
If the
ma'am.
same patient BP 80/40, pulse rate 140, hemoglobin 5, bleeding heavily from down. What is the appropriate management? Initial management also. There is like, if instead of medical management, if they give resuscitative measures, that would be the best option. If not, immediate hysterectomy would be the answer. So please read the question, understand what they're asking, rule out each option. Okay, this is not correct. This is not correct. Then choose the proper answer. You all know, but the thing you get, like your mind will get occupied. Okay, here, see, that's why I have put this. Does not desire future fertility, just to change, you twist your mind. Because when we mention this, we'll think that okay, hysterectomy is the best option. But here they ask the initial option. You got me? So please don't get trapped with the examiner's things. They will do all these things because they have to like make the good questions. So here
Yes.
the answer would be medical management.
Medical.
The same option, the best first line medical option for heavy bleeding would be Tranixam.
Chennai.
Okay, in the same question, if there is no mention about the fibroid, there is no fibroid, okay, the patient has just come with heavy bleeding, okay, then the best first line medical option would be
Tranexamic acid.
Tranexamic acid.
that is initial management. So here tranexamic acid is initial management, but the best option for heavy bleeding without any structural abnormalities, like you have ruled out
Combined
a
Fibroid.
palm, you have
Yes.
ruled out the palm. There is no polyp, there is no adenomyoma, there is no leiomyoma. You have ruled out all the structural causes. Then the best first line medical management would be LNG-IUS.
OCPs.
Okay, ma'am.
Very
Very
Even I wrote
important. Very
inside.
important. What is LNG-IUS? It's just a coil in which you have hormone which is inserted into the womb. Very popular nowadays. It's known as Mirena. It has avoided
Very
many hysterectomy cases. So if the same scenario, if they give that, the structural abnormalities have been ruled out. Now, what is the best first line medical option for heavy bleeding? That would be Sharanya. What is the answer? LNG-IUS.
LNG-IUS, ma'am.
Here, because the question I have mentioned that 4 centimeters fibroid is there. That's why you should go with the Tranexamic here.
Okay, ma'am.
Got it?
Yes, ma'am.
When is myomectomy preferred? Anisha, Dr. Anisha, when is myomectomy preferred?
Mm,
Of the 4 options, when is myomectomy preferred?
desire future fertility.
Yes, very good. So any patient who desires future fertility, we should go with myomectomy. So now we will be going just crisply about the management options. Okay. So Piyush, what is the absolute indication for hysterectomy in fibroids? Is asymptomatic fibroid requires any treatment?
Recording in progress.
Everyone sleeping? No one is answering?
Ma'am, failed medical management.
With completed family.
Yeah.
The
So,
answer is C.
yeah,
See,
answer is failed medical management with completed family. Correct. So, very important topic. You should have an idea when to choose what. Okay. If a patient is a young patient who is less than 40 years, who has not completed the family, subfertility or infertility, who is having a fibroid and strong desire to retain the uterus, then you go with myomectomy. What is myomectomy? You remove only the myoma,
I'm
keep
right.
the uterus intact. And when to choose hysterectomy? When the symptoms are very severe, she's having heavy bleeding, she has finished family, I have all the kids, no further like large multiple fibroids are there, you have gone with medical management and medical management is failed, and the patient is telling, I cannot just come and visit you on and off. I want permanent solution for this. I wanted to get a definitive treatment. Then you go with hysterectomy. So, as we were talking, surgical removal of fibroids only is myomectomy. Removal of complete uterus is hysterectomy. Uterus preservation is done in myomectomy, and fertility preservation is done in myomectomy. So, age less than 40 years who desires fertility, myomectomy is done. So, what is the main risk with this is the risk of repeat surgery is high because the chance of recurrence of fibroid is high in myomectomy. You are completely removing the womb. Where does this myoma arise from, Zuleka? Where does this myoma
Myoma,
arise? Leiomyoma.
Leiomyoma is uterus.
Yeah,
Wall of
muscle,
uterus.
myometrium.
Muscle,
For
yes,
uterus,
Muscle, yeah.
myometrium.
myometrium. So when you have removed complete uterus, is there any chance of recurrence? No. So is
No,
there any
no,
chance of repeat surgery when you do hysterectomy? No.
no.
Okay.
Because all of things we removed.
Yeah, everything we removed. And
Removed,
see,
yes.
once we open up the uterus and you take the myoma, again you close. And the next time when she becomes pregnant, there is a chance of rupture uterus at the
Rupture.
time of labor. So that is the only negative thing that you have to keep in mind about myomectomy. Am I clear?
Yes.
So
Yes, ma'am.
always once a scenario is given, assess the scenario. Your priority would be whether the patient is hemodynamically stable or not. If not stable, resuscitative measures with IV fluid, IV access, blood transfusion if needed. Every time, if the patient is in reproductive age group, if they ask what is the initial management with heavy flow and they didn't give that fibroid and all, then always rule out pregnancy. That is the first thing you should tell, and then initiate medical therapy with Tranxa. Then you go with the scan, try to find out the reason, palm or coin, then proceed accordingly. Am I clear? According to the
Yes,
situation,
ma'am.
management varies. If the patient is having asymptomatic fibroids, nothing to be done. Just observe. Reassure the patient, tell the patient, come every year, do a scan, see how fast the fibroid is growing. That is enough. Observe. If the patient is coming with heavy bleeding and the patient is stable, the thing would be tranexamic acid. And the other options, like, see, now you have here the other options, like here you have, I'm sorry, it went to the other slide, I'm sorry. So here the other options are like, if there is symptom and heavy bleeding is there and the patient is stable, you can, first option would be Tranxa. Why you will not give OC pills in fibroid? Because OC pills will increase the size. What is the reason for
Size.
fibroid? Estrogen only will increase the size. Why this LNG-IUS is not indicated in fibroid which is more than 3 centimeter? Because it is distorting the cavity. When the cavity of the uterus is distorted, will this T shape stay properly? No. So
No.
that's why if there is any structural abnormality which is more than 3 centimeter, or like if they gave something like that, better you avoid LNG-IUS. So for palm, try to avoid LNG-IUS. For coin, you can put LNG-IUS. For palm, always, whatever surgical abnormality is there, remove that. Either polyp, either adenomyoma, or whatever it is. But for adenomyosis, you can go with medical treatment like LNG-IUS or GnRH agonist, or like even OC pills are also good. Okay? Because
Yes.
adenomyosis, I told you, it is happening because endometrium is inside the myometrium. If we can stop periods, then adenomyosis will come down. That's why adenomyosis, you can opt the other treatment. If it is fibroid and fertility desired, directly go for myomectomy. Complicated family, persistent symptoms, go for hysterectomy. Patient is not willing for surgery, she has multiple comorbidities, go for uterine artery embolization in selective cases. Am I clear? Now you should be able to answer any question of abnormal uterine bleeding in a reproductive age group lady. You have any doubts, you can ask me, I'll clarify that. And I would request all the students today only, whatever you book you have, like you just go with this topic and try to solve these questions. If you have any doubts, you can personally ask me the doubt. I can like explain you. Am I clear? So very important topic, AUB. So this is almost I covered maybe 10 to 15 questions. If at all, if AUB comes, you can solve this. Okay? Anyone having any doubts?
Yes,
I'll
ma'am.
clarify and go for a few further. Any doubts?
No doubt.
Recording in
No doubt?
progress.
Okay. Anisha, read the next question.
Yeah. A 47-year-old woman with irregular menstrual cycles, hot flashes, and the mood swings asked about starting hormone therapy. The most appropriate management is start combined OC pills, start combined hormonal therapy, start low dose vaginal estrogen, and the recommended non hormonal management only.
So now what? What you choose? So what is your diagnosis over here? It's
This menopausal syndrome, perimenopause.
perimenopause, not menopause. To tell us
Perimenopause.
menopause, you should have 1 year of amenorrhea. The patient is having irregular menstrual cycles, but still she has like hot flushes, all the other symptoms. So the best diagnosis is perimenopause. So now you have to start hormone therapy. So now when to start, what to start? Tell me.
Start combined hormonal therapy.
Yeah. So you are telling option B. Your option is B, right?
Yes.
Anyone, any other opinion?
It can be non-hormonal management also.
Okay, the most appropriate. So anyone else? So what is MH3? What is MH3? MH3 is menopause hormonal therapy. So what is the difference between combined OC pills and menopause hormone therapy? So here the two things are different. Combined hormone therapy means this is menopause hormone therapy. Okay. Combined oral contraceptive means what you know, right? COC pills. That is given for what? For contraception. So what is the difference between MHT and COC? So the COC has high dose of estrogen, which will prevent ovulation. So if there is no ovulation, it will prevent pregnancy, right? So if a patient who comes, I want contraception, you give combined OC pills. If the same question tells 56-year-old, my periods have been stopped since 1 year, I have mood swings, I have hot flushes, give me treatment, then the best option would be menopausal hormone therapy. Here, the patient is 47. So still the patient is having cycles. So we cannot tell whether there is chance of pregnancy. So that's why here we should go with combined oral contraceptive pills, because still there is chance of pregnancy. So to prevent ovulation, the most appropriate management would be hormone therapy. Non-hormonal therapy is given only if it is very mild symptoms, dear. Here you see the patient is having hot flashes. She's also having mood swings and she's asking about starting hormone therapy. Then why will the non-hormone therapy will come into the option? So you have only doubt between whether it's A or B. You have doubt whether it's this or this. So what determines? The age determines. Understood, Anisha?
Yes, ma'am.
So what is the answer here?
So the answer is A. Start combined oral contraceptives.
Very good. So Why? For perimenopausal woman who is 47 with irregular cycles and vasomotor symptoms who desire hormonal management, combined OC pills are the most appropriate one. Contraceptives provide more higher and more consistent hormone levels than MHT, and it effectively manages the irregular cycles also and also cover the vasomotor symptoms with contraception. So here the main thing is perimenopause pregnancy is still possible. So we can choose COC pills till 50 years if no contraindication. I think you know what are the contraindications for COC pills. So if there are no contraindications, you can go with combined oral contraceptives. Am I clear?
Yes.
Yes, ma'am.
Piyush, you are there? Why Piyush is today silent? Sleeping Piyush?
Women empowerment.
Oh, then Shahanas? Shahanas? Rajesh is also silent today. Ganiyat?
Recording in progress.
Who is on and off recording? Please, silent guys. I cannot listen to my very loud voice again. Okay. So now who is going to read this question? Come on.
Patient.
Which patient of
Who is
PID
reading?
Okay.
which Rabia? Which
No,
patient
Rabia.
of PID?
We'll give the other one who are silent.
Okay, ma'am.
Maybe Shahanas, Ganiyat.
Progress.
Who is reading?
Shall I read?
Yeah, read, sure.
Which patient with pelvic inflammatory disease requires admission? And
Yeah.
my answer would be pregnant woman, ma'am.
Yeah, very good. Great. So this is, who is this, Sandhya or Sharanya?
Saranya, ma'am.
Okay. So in which patient PID requires management? Do you have a list of it, Sharanya?
Ma'am,
Progress.
Yeah. So any patient who is not responding to oral antibiotic or who is febrile, who is showing acute abdomen features like you cannot touch the tummy and all, where you cannot rule out tubo-ovarian abscess or any other acute abdomen, you have to admit that. And any pregnant lady who comes with PID also, we should admit. So these are the indications for admission. Keep in mind, maybe this pregnant woman is correct, but for next time you should be correctly telling. Okay? Next,
yes, ma'am.
Sandhya, Shahanaz, Sunil Kumar, Rajesh, Piyush,
Can I read, ma'am?
Naushin. Yeah. Who is this?
Sorry, I
Sunil?
got busy. Right now, I
No,
am
no
written to
worries.
the screen.
Yeah, no worries. Tell, read this.
Okay. 51-year-old woman present
Mhm.
with severe hot flashes, night sweats, and sleep disturbances for 8 months. Last menstrual period was 2 years ago. No history of VTE, breast cancer, or liver disease. BMI is 26. Blood pressure is normal. What is the most appropriate management? Clonidine, that combine estrogen progesterone therapy,
Progress.
estrogen, Tibolon, or SSRI.
So what is your option?
So woman is a postmenopausal woman.
Yeah. So your diagnosis is menopausal lady with menopausal symptoms,
Yes.
which is severe. So we need to treat her. What is this summary? Start summary. Okay.
SSRI.
It's okay.
We
Tell.
can start option
B.
C, estrogen alone.
So Piyush, if you start, see, let me tell you, you have uterus, right?
Yes, ma'am.
Okay. So these are two ovaries. So these ovaries secrete estrogen, which is very important for a lady to have, like, it will avoid all these hot flashes, night sweats, and all these things will be avoided by estrogen. But if you give estrogen alone, what happens to the endometrium? The
Causes
endometrium will
endometrial.
thicken.
Right.
Later on, it will cause what? Endometrial cancer. So, if the patient asks you, you gave me estrogen and my symptoms all relieved, but one or the other day, if I get cancer, who is responsible?
Progress.
So estrogen is responsible for that.
So, you should always combine estrogen with progesterone in a patient who is having the uterus in situ. If the patient's hysterectomy is done, and then if she complains the same, then you can give estrogen because there is no uterus. Am I clear, Piyush?
Yes, ma'am.
So
Yes,
here
ma'am.
the answer is estrogen and
Combine
progesterone.
estrogen.
And what is important here, they have given no history of venous thromboembolism, no history of breast cancer, no history of liver disease, BMI, no smoking. These are all what? Contraindications to start, if at all, if these anything is present, that is contraindications. So they have ruled out the contraindications to start HRT. So that's why here the answer would be B. Okay. Now the next question. Who is going to read the next question? Yeah, Ganiyat, read.
A 48-year-old woman
Ah,
underwent total abdominal hysterectomy
hysterectomy. Hmm.
for fibroids 1 year ago. She now
Mm-hmm.
has severe vasomotor symptoms.
Mm-hmm.
No other risk factors.
Mm-hmm.
Best therapy, combined MHT. Please, what is MHT?
Progress.
Okay. So now what
Estrogen
is your option?
alone, raloxifene,
Hmm.
progesterone alone, calcium
Hmm.
plus vitamin D only.
So now what will you choose in this situation? The patient is
Please,
having
what is
severe vasomotor symptoms.
what is the MHT? I don't know what it means.
That is menopause hormone therapy. That is what we were telling. I'll teach you that in a moment.
Hormone
What is
therapy.
that?
Okay.
Mm.
Okay. I'll give her A as the option.
So what is your answer? A, B, C, D, E?
Because she had total abdominal hysterectomy, I want to give her combined estrogen, combined
Okay.
MHT.
You will give combined MST. Zuleika, Rabia, Piyush.
Here we can
Ma'am,
give Madam
estrogen
alone.
estrogen
Then,
alone because no uterus.
B,
Very good.
Because
B,
no uterus.
B,
Estrogen
ma'am.
alone.
See, yeah,
B.
The
Ganiyat, here,
estrogen alone.
because I was telling you already the patient's uterus is removed and the one which causes the severe vasomotor symptoms are estrogen. So we can give
Estrogen.
estrogen alone. If there is no uterus, why you wanted to give progesterones? I'll tell you in detail about that. Ganiyat, you will be understanding once I teach the topic, okay?
Okay, ma'am.
Now, next one. Who is going to read the next question? Mifra.
A 52-year-old woman with a severe hot flashes, history of DVT 3 years ago after long travel. Currently well. Best management, start oral combined menopause hormonal therapy, start transdermal estrogen, tibolone,
Progress.
SSRI, progesterone only.
Now, so now DVT is a contraindication to start with estrogen therapy. Now the patient has come to you with what? Severe hot
Progesterone
flashes.
only.
Only progesterone, ma'am. E.
I'll kill you. All the girls, I'll kill you. Progesterone will not do anything. Whatever menopausal symptoms, hot flushes, night sweats, vaginal atrophy, these are all because of estrogen deficiency. We give progesterones only because when we give estrogen, the estrogen will cause endometrial hyperplasia. to prevent the endometrial hyperplasia, we just substitute progesterone in the treatment. As of progesterone alone will have no use in any patient who has menopausal symptoms. Am I clear?
Yes, ma'am, very clear.
Yes, ma'am.
This you keep in mind. So here severe hot flashes means the patient is having some like hot flashes where we cannot give estrogen, then we will go with SSRI therapy. What is SSRI?
Serotonin, selective serotonin reuptake
Yeah,
inhibitor.
selective serotonin reuptake inhibitors, which are like which soothes the
Parametrically.
hot flushes. These are usually given like these are antidepressants like
Yes,
SSRIs.
ma'am. It's an antidepressant.
Yeah, SSRIs are antidepressants. So these are given antidepressant. It also has a good role in hot flushes when there is contraindication to estrogen therapy. When any contraindication to estrogen therapy, we can go with non-hormonal options like SSRIs, SNRIs or gabapentin. Am I clear?
Yes.
No role of progesterone. Progesterone is given only if the uterus is there and we are giving estrogen. To protect the uterus from endometrial cancer, we add progesterone. Otherwise, progesterone alone will have no therapeutic value. Now coming to the next question. 55-year-old woman treated for estrogen receptor positive breast cancer complaints of hot flashes. So now what you know, these are all the contraindications for hormone therapy, breast cancer, breast cancer.
In
So these are
progress.
all. Now what you do? What is the best treatment for her?
Is paroxetine.
Paroxetine D.
Very
SSRI.
good. Very good. Why paroxetine? Tell me.
Is it SSRI?
So
SSRI.
if so it's very simple that whenever the estrogen, tibolon, this tibolon is there, na? Tibolon is, what is tibolon? This is selective estrogen receptor modulator. Tibolon is selective estrogen receptor modulator where it increases the estrogen. Okay. But the problem is whenever the estrogens are increasing, positive breast cancer. So that's why you cannot give any treatment which increases the estrogen level. So that's why here the management would be paroxetine because systemic hormone therapy is contraindicated in breast cancer. Now coming to the next question. Who is reading next question? Zuleika, Rabia, anyone?
Can I read?
38-year-old woman present with amenorrhea for 8 months, FSH elevated on 2 occasions. Diagnosis premature ovarian insufficiency. The best management is
Recording in progress.
no treatment, MHT until age of 50, combine OCPs, progesterone early, bisphosphonate. FSH are high, premature ovarian failure. So men best, I think, OCPs.
Bisphosphonate. OCP we don't need as she's having amenorrhea.
Okay, then Mifra, you clear it.
It's like a
Very good.
like
So
a
this is how
premature
you should think. If you are
precocious
reading a
puberty, she's
question, very
having.
good, very good. If now I will be telling you, see, this is the one I wanted to teach you. Okay. So if a woman who is on menopause or who has menopausal symptoms and the lady has intact uterus, that means hysterectomy is not done, but you have to treat the menopausal symptoms. Then you will go with estrogen with progesterone because progesterone will avoid endometrial cancer. If there is no uterus, you give only estrogen because uterus is not there. If there is any history of VT, venous thromboembolism, you have to avoid systemic estrogen because estrogen is thromboembolic. It causes thromboembolism. So in that situations, you have to go with SSRIs or SNRI. If breast cancer, then also you have to avoid estrogen. In this also you will go with the same. Premature ovarian insufficiency, you will go with menopause hormonal therapy. Why not OC pills? I'll explain. Don't worry. I'll explain in the next slide. Okay. If the patient complains of only vaginal dryness, no other symptoms, then local estrogen would be more than enough. Why you wanted to start full MHT? And always keep in mind, if it is beyond 50 years, you can start MHT very confidently. But if it is beyond 60 years or more than 10 years after menopause, already the cardiovascular symptoms like estrogen is always keep in mind, it is protective against heart attack. Once the estrogen is not there, your blood vessels will have atherosclerosis, your blood vessels will start aging. So, for more than 10 years, if there is already menopause or she is more than 60 years, if you start MHT at that age, there is increased risk of cardiovascular complication. But when you start ideally at 50 years or less than 50 years, no worries. No worries, no complications. Am I clear? Now, in this question, why doc? Why not OC pills, combined OC pills? You told that up to 50 years you can give OC pills. Here the question has mentioned that the patient has already stopped periods, attained menopause. Then why you wanted to give OC pills? So this one, this is another slide. Progesterone protects endometrium. If estrogen is contraindicated, like see if the question is telling the patient is having migraine or the patient is having family history of VTE, then instead of giving oral estrogen, you can go with transdermal estrogen, which has lesser thromboembolic side effects because it doesn't have like the liver, it will not, if you take any medicine, like if you take oral estrogen, it will go to liver, it will metabolize and it will enter into the whole system, will cause thromboembolism. Transdermal will avoid the first pass metabolism in liver and lessens the chance of venous thromboembolism. So that's why if oral is contraindicated, there you can even try transdermal if the situation is like obese lady, like she family history of VT. In that situations, we can go with transdermal estrogen. Okay. So absolute contraindications are any cancer, breast cancer, endometrial cancer, active liver disease, any unexplained vaginal bleeding or active venous thromboembolism, it should be contraindicated. And the same question here, see a 52-year-old who got menopause 2 years ago, now severe hot flushes, husband is vasectomized. The best option would be always combined because here already she got menopause. So there is no need of OC pills. So here the answer is combined MHT. No contraception is required. So when to choose what? Menopausal hormone therapy is to treat menopausal symptoms like hot flushes, night sweats, vaginal dryness and all. What is the estrogen dose in MHT is very low. It just has the dose which will physiologically replace the menopausal symptoms. But combined OC pills will have higher dose of estrogen which will suppress the ovulation. So if you take MHT and you feel like no, the patient won't become pregnant, no, because ovulation can happen in MHT therapy because the estrogen is very low in that. Whereas in combined OC pills, the high dose of estrogen will suppress ovulation. So in the first question, when the question tells the 47-year-old lady, I'm sorry, who is menstruating where there is chances of getting pregnancy, we will go with combined oral contraceptive pills. In a patient whom they attained menopause, no periods for more than 12 months or husband has already been vasectomized, then Why you have to give high dose of estrogen, which will have thromboembolism effect, which will have endometrial cancer? In that situations, you will go with menopause hormone therapy, which is the first line in premature ovarian failure until 50 years, because already ovarian failure has happened. There is no chances of pregnancy. Then why should you give high dose of estrogen? Am I clear? This is the last page in my class. Please concentrate for this page, dear. I know you people are feeling hungry.
Ma'am, I have a doubt, ma'am.
Yeah, tell me.
Ma'am, in this previous question, it has noted that the amenorrhea. No, ma'am, in the other previous question, amenorrhea for 8 months. So in this, the amenorrhea started. So why not we go with the combined OCPs, ma'am?
That's what I was telling you. See, combined OC pills will have high dose of estrogen, dear.
Okay,
So
ma'am.
here already you have diagnosed that it's a premature ovarian failure. So
Yes,
what
ma'am.
is the difference between high dose of estrogen and with the MHT is like MHT will have low dose estrogen and it will only correct the menopausal symptoms.
Okay, ma'am.
Here, is there any indication to stop her ovulation? Because already she is not ovulating. She doesn't have any follicles. So why
Ma'am,
you
Yes.
have to
last
give?
question, she doesn't have any postmenopausal symptoms like to give
But
combined
see,
hormonal therapy.
but listen to me. Any premature ovarian failure who is diagnosed. See, when do you check FSH? If a 50-year-old lady comes with menopausal symptoms, will you check FSH? No, right?
No, ma'am.
Only for a young lady who comes, then only you check FSH. So here they have given that FSH is elevated on 2 occasions. That means the diagnosis is premature ovarian failure. Okay. Now, whether to give any hormone therapy or leave her alone. If you don't give any hormone therapy, you left her alone, maybe after 2 years, she may come with again perimenopausal symptoms.
Okay, ma'am.
Rather than waiting for 2 years to get the symptoms and then treat, to get the effectiveness of hormone therapy, you should treat as soon as possible. And a lady should have her periods till 50 years for her health to be in a good condition. So 38 year, now only she got a menopause. So it's always safe to start MHT until 50 years.
Okay, ma'am.
To
Yes,
protect
ma'am.
the lady. If now you don't start, after 2 years, she come with symptoms, severe symptoms. That time, even if you start, there might be right reluctant to act. So
Okay, ma'am.
any premature ovarian failure, you have to start MHT and you have to give MHT till what age? 50
50.
years. That is routine menopause age. After routine menopause age, if the patient tells, it's okay now, no worries, I'll stop this, then it's okay. After 50 years, see, how many of our mothers are menopause after 50 years? How many of them took hormone replacement therapy? Not required. So, physiologically, till she attained menopause, you have to treat a patient with a premature ovarian insufficiency with MHT. Why not combine OC pills here? Because already there are no follicles, there is no chance of pregnancy, there is no ovulation. So why you have to give dose of estrogen? Okay?
Yes, ma'am. Sure,
Karthik,
ma'am.
I'll give you now.
Piyush, you are in the clinic, I understood. Ah.
Sorry, ma'am.
No worries, dear. I know it's difficulty. Like it's all you have to be in the clinic, you have to work and you have to do. No worries. I have no regret in that. Just mute yourself, okay? So now you got what I'm telling.
Yes, ma'am. Yes, ma'am.
Very
Thank you, ma'am.
today, whatever 2 topics I have discussed is very important. High yielding questions will come upon this. So just try to solve this. So these are like, see, that's what I was telling you. If a patient comes with an menopausal symptoms, you have to treat with estrogen alone. There is no need of progesterone if the uterus is absent. If uterus is present, then only progesterone. If uterus is not there, then no need of progesterone. And this
Ma'am,
estrogen therapy will improve bone health, It will improve cardiovascular risk. That's why we are telling why we should continue this MHT till 50 years, because it will give bone protection, it will give cardiovascular risk reduction. That's why it's very important. But if you give the high dose of OC pills, high estrogen, you know, right, in contraceptive pills, what is a contraindication? Hypertension, cardiac disease, MI. These are all contraindications for OC pills. Am I right? Because higher dose of estrogen will have negative effect. If lower dose estrogen, it is giving protective effect in a menopausal lady. Am I clear? I think someone was having some doubt. Tell me here.
Ma'am, if post-hysterectomized patient come with the postmenopausal symptom, then ideal should be the progesterone only.
No, sorry. Estrogen only.
Estrogen
Post
only.
Is not.
post-hysterectomy.
Yeah, dear, post-hysterectomy. See, first you understand, Rabia, what will cause these hot flushes? It's not
Okay.
progesterone deficiency, it's estrogen deficiency which causes hot
Hot flash.
flushes, all the symptoms, vaginal dryness. So the treatment is estrogen. Why the hell you will give progesterone? We are giving progesterone only if the uterus is there, because estrogen will cause endometrial thickness. That
Okay.
thickness will cause cancer of the endometrium. To avoid that, when I am giving estrogen, I am substantiating it with progesterone, which will calm the endometrium and which will avoid endometrial cancer. I am
Okay, ma'am.
treating the menopausal symptoms. But after 10 years, if she becomes endometrial cancer patient, is my treatment correct?
No.
The patient will ask, why did you give the treatment which will cause endometrial cancer? Then what is there in you? Like what answer you will give? So progesterone is given only to avoid a complication of endometrial cancer which occurs because of the estrogen therapy. Otherwise, progesterones have no role in treating the menopausal symptoms. Only estrogen has. One more
Okay.
exception with that is if a patient is having endometriosis. Okay. What is endometriosis? Endometrium is present everywhere outside the uterus. Am I clear? In that patient, already ovary is removed, hysterectomy is done. Now you are giving menopause hormone therapy. Okay. In that patient, what will you do?
Only estrogen.
If you give only estrogen, the endometriosis which is there everywhere in the, like in the peritoneum or in the skin, everything will start recurring. So only exception in which after hysterectomy you give estrogen with progesterone is
In
endometriosis.
endometrium. Okay, now I got it.
Why I didn't tell this earlier? Because you will get confused.
Yes, ma'am.
So when a patient is having endometriosis and hysterectomy is done because of endometriosis, in that situation only you will give estrogen with progesterone. Otherwise, all hysterectomized patient only estrogen therapy is required. Am I
Yes,
clear now?
perfect. Yes, ma'am,
Okay.
perfect.
These two
Thank you.
topics are very important here. So after reading this, see, listening to my class, you people all will feel, wow, very nice, very nice. But until you read it again, you make your concept strong and you solve 10 to 15 questions on this topic, then only your knowledge, like you can rock the exam. Okay?
Okay,
Everything I
ma'am.
teach, you listen, you won't make any notes, you won't prepare anything. Next day, if I'm asking you the same question, your reply will be the same, old wrong answer. And you will think, no, doctor told me very good explanation. I remember, but I don't recollect. That's why strengthen your concept. You try to strengthen your concept. Whatever confusing question in the exam they give, you will get an answer.
Ma'am,
So read the question, each and everything. Yeah, tell me. Yeah.
I'm sorry to interrupt, ma'am.
No.
I
Tell
have a
me.
doubt, ma'am.
Yeah, tell.
If a 45-year-old lady
Hmm.
comes with very mild symptoms of menopause
Hmm.
and her cycles are irregular, Let's keep it that way. What would be the treatment of choice, ma'am?
See, you told the cycles are irregular, but
Yes,
you asked the patient whether that heavy bleeding and whether that cycles are bothering.
okay, ma'am.
Okay. Usually for mild menopausal symptoms, you will not start this hormone therapy. You will just reassure them. You tell them to do what you know, avoid hot temperatures, wear loose garments, cotton garments, and all those things would be enough if irregular cycles, not heavy bleeding. But if
Okay.
she tells irregular, heavy bleeding, and whatever symptoms is disrupting her quality of life, that is
Yes,
what
ma'am.
important is. Even if mild symptom, if she's telling, oh, because of this mild symptom, I cannot, my quality of life is disturbed, I want treatment, then can't you say that, no, 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 it is mild only, no need treatment, go, go. You cannot tell that.
Yes,
If the
ma'am.
patient is insisting for treatment because it is affecting, then you have to treat. If the patient is telling it's only mild, it's okay, no need.
Okay, ma'am.
No need.
No need of any treatment if the patient is not insisting on any treatment. Yes, ma'am.
Yeah, if it is mild symptoms and irregular cycles alone, you need not to treat.
Ma'am, and if her quality of life is affecting because of the bleeding, like heavy bleeding and stuff,
Then,
what would be the... Yes, ma'am.
then OC pills. Up to 50
Okay.
years, OC pills.
Okay,
Because
ma'am.
if you give MHT, it will
Yes,
only, the
ma'am.
dose of estrogen is only just like a physiological replacement. It will not, see, what is the reason for 45-year-old who is having irregular heavy flow and ovulatory cycles,
Yes, ma'am.
right? So for that, the dose of estrogen should be higher enough that it suppresses the ovulation. Then
Yes,
only
ma'am.
it will act properly, right?
Yes, ma'am.
So in that situation, irregular heavy cycles, you have to give OC pills up to 50 years. But see, always keep in mind the contraindications for these OC pills.
Yes,
There
ma'am.
are contraindications. Migraine with aura is contraindication. Severe hypertension uncontrolled is contraindication. Past history of venous thromboembolism, breast cancer survivor who is on treatment is contraindication. Severe liver disease is contraindication. So when these contraindications are there, not to choose OC pills, try to go with the other options available. Am I
Okay, ma'am.
clear?
Yes, ma'am.
No.
Thank you so
Anything
much,
else?
ma'am.
How was the class? See, like this
Excellent,
is
ma'am.
topic wise.
Ma'am, I have a doubt.
Tell Mifra, tell. I'm
For
open to you.
example, a 62 years old menopause woman comes with postmenopausal symptoms. She has passed 10 years of menopause. So hormonal therapy will be no use at that time. Should we go for
No.
bisphosphonate?
See, first of all, if the patient is 60 years, you should ask when did the menopause she attained. Okay. So if you told 62 years, if she attained menopause as 52 years, now already 10 years she was not on any treatment, right? Now, how severe the symptoms are? If the patient is telling very severe, then you have to tell that I can start with MHT, but there is increased risk of cardiovascular. Like the problem is there was a trial that is known as there was a study, okay, where they told that this hormone replacement therapy increases the cardiovascular risk, and kalas, all the gynecologists stopped giving hormone replacement therapy. After that, another study came out. Why is it appropriate or not? So in that study, it was clarified that MHT, if started at 50 years, it is cardioprotective. But if we are starting the same MHT after 60 years, there is increased risk of cardiovascular disease because already the insult of estrogen deficiency on vessels causing atherosclerosis has happened till 60 years. Then upon that, you are giving estrogen which will cause more thromboembolism. So that's why if in that situation is there, you can always better go with other options like SSRIs. If hot flushes are severe, SSRIs. If vaginal dryness is severe, local vaginal estrogen will not cause any high risk. And she is like there are no other options and you have to give only OC pills, then only you give, sorry, MHT, then only you tell the risk and then give it. You got me now?
Yes, ma'am. Understood.
So the question will be in that way only. You are not a specialist. So you will not get very complicated. See, in MHT and in AUB, whatever I told, no one will go beyond this. But know the basics. This is the thing, this much you should know. No one will ask beyond this. Even that 50, 60 years is enough. It is very high for you. It is for a specialist like us, not like you. Okay? For you, only these basic things are enough. Like, okay, if uterus is there, what you give. If breast cancer is there, what you give. SSRIs, SNRIs. And one more thing, patient on tamoxifen. Patient on tamoxifen, then usually among SSRIs and among SNRIs, SNRI is preferred because tamoxifen has drug interaction with SSRI. So when any patient, breast cancer survivor who is taking tamoxifen, what is the best drug of choice for hot flushes would be SNRIs, venlafaxine, not a fluoxetine. That is one more bit, which is a complicated bit that can come up in your GP exam. Beyond this, no other questions. Believe me. Just go through the topic, make a notes of it, prepare these questions, and when you solve, you will see almost these questions only. Okay?
Yes, ma'am.
So can
Thank
we
you.
end the class?
Yes, ma'am.
Zuleka, Mifra, you, Rabia, you have listened the previous class and this class. Which type of class you liked?
Ma'am,
Okay, ma'am.
personally, I
Yes.
like both. Every class of you.
Thank you, Rabia.
Yes,
Thank you
ma'am.
so much.
Yes, ma'am. Every class is very good and informative.
Ma'am,
Thank
are
you.
you staying in Abu Dhabi?
Good, ma'am.
What, what dear?
Are you
Both
safe there in Abu
classes are
Dhabi?
good,
Yeah,
but
I'm in Dubai, dear. So that's why I'm safe here. I think in Abu Dhabi you have many
Ma'am,
problems.
I
this
am.
type of class is more good. This type of class is more good because in this way we cover the topics.
That's,
Yes.
why I wanted to tell you this is like, this is my regular way of taking regular classes. But when it comes to what you mock means, already topics are covered. So we just get questions, answer, questions, answer. This is like, see, I will be teaching now. I think I have finished labor module. Now I'm going into the other module. So in my regular sessions, we will be teaching each and every topic in this way so that your base will be strengthened. And now my thing
Ma'am,
is like,
ma'am,
uh, uh,
we are not nowadays in the regular classes.
I know,
So
dear.
how,
It's like,
yeah,
it's
how
like, I
we,
know. Uh,
so how you can, your topic-wise classes,
you wanted to
only
know.
option is Sunday?
Zuleika, that you have to talk with personally with Munjal sir. You can ask him, sir, can I attend Dr. Ramya's gynae classes alone and you can give me something like that? I don't know. Let me first.
Ma'am, we
Okay,
give the
okay.
request, but we give the request to Pallavi, but no response.
I'll talk to Pallavi, okay? I'll ask
Thank
Okay,
you.
Pallavi.
So
okay.
nice of